Postoperative care. The patient's recovery is first handled in the post-anesthesia care unit, or PACU. General anesthesia is administered to patients to induce a state of unconsciousness, produce memory loss, and provide analgesic support during a surgical procedure. Patients who undergo general anesthesia may lose the ability to spontaneously breathe or have an irregular breathing pattern, which requires some form of ventilatory and oxygenation support. Anesthesia and analgesia medications may also alter other systems and affect the level of consciousness, mobility, blood pressure, and heart rate. Nursing care includes management of respiratory, cardiovascular, neurological problems, as well as pain or discomfort. In addition, temperature, gastrointestinal, and urinary problems may also need addressed. The surgical wound is also a primary area of focus. The surgical patient will remain unconscious until the anesthetic agents are stopped. Following anesthesia, the surgical patient requires vigilant monitoring to support respiratory and cardiovascular function until the return of spontaneous reflexes and hemodynamic stability. The postoperative period, care of the patient following surgery, begins as the patient enters the PACU. The close proximity of PACU to the OR minimizes transportation time and provides the patient and PACU staff with immediate access to anesthesia and OR staff while the patient is recovering from anesthesia. The primary goal of nursing care in the PACU is to monitor the patient for complications of anesthesia and/or the surgical procedure. Three phases of post-anesthesia care include phase 1, phase 2, and extended observation, which provide different levels of care depending on the patient's needs. Patient moves through the levels of care depending on their condition and the type of anesthesia they received. Rapid PACU progression, or RRP. If a patient is doing really well, the patient may go rapidly through phase 1 to phase 2 and into an inpatient unit. Fast tracking is another accelerated system of care in which involves admitting ambulatory surgery patients directly to phase 2 care. These types of programs are used to facilitate patient recovery and are specific to each surgical procedure. The goals of fast tracking, or RRP, include to cut costs and increase patient satisfaction, to decrease overall recovery time and the length of hospital stay, and to decrease morbidity. The patient's safety is the primary factor determining where and at what level we provide postoperative care. The initial recovery period, phase 1, handoff report is the first interaction that occurs. It is a standardized and interactive report from the anesthesia care provider to the postoperative care nurse. The ACP should stay in the PACU until the PACU nurse accepts responsibility for the care of the patient. Basic life-sustaining needs are the highest priority. The patient is most prone to complications at this time and requires constant vigilance. The patient assessment may include management of artificial airways, pulse oximetry to assess oxygenation, transcutaneous carbon dioxide and end-tidal capnography monitoring to detect respiratory depression, continuous ECG monitoring for changes in heart rate that may indicate pain, anxiety, bleeding, hypovolemia, or abnormal electrolytes, frequent blood pressure monitoring for complications of hypo or hypertension, frequent assessment of circulation, including body temperature, cap refill, skin color, and moisture, frequent assessment of the neurologic system, level of consciousness, orientation, sensory and motor status, and pupils, frequent assessment of intake and output, and fluid balance, management of IV fluids and medications, management of catheters and drains. The goal is to prepare the patient for phase 2 or an inpatient unit. To manage the patient that has received anesthesia, various equipment is required. If the patient is ventilated, a ventilator will be present with suction set up for airway management. Various artificial airways are also required in the PACU if a patient loses spontaneous respirations, thus requiring mechanical ventilation. Various oxygen delivery systems, nasal cannula, face masks, etc., are required that may be specific to the type of surgery. So for a facial surgery, you may need a mask versus nasal cannula. Various sizes of blood pressure cuffs are required with equipment for invasive blood pressure monitoring if patient has an arterial line. IV supplies and IV fluids may be necessary to replace fluid loss in the OR. Stock medications such as antibiotics, reversal agents, analgesics, medications to control blood pressure and heart rate, and anxiolytics. And then stock items may also include Foley insertion kits, dressing supplies, and NG tube Salem supplies. Handoff reports should be standardized and interactive, allowing for questions and clarification of information. The anesthesia care provider should remain in the PACU until you accept responsibility for the nursing care patient. General information includes the patient's name, age, the surgeon who did the procedure, the surgical procedure the patient underwent, indications for surgery, medical history, current medications, and allergies. An example would be, this is Miss Cindy Smith, a 66-year-old female. She had a screening colonoscopy with Dr. Clark. She did fine and is awake and alert. She is stable and has a 20-gauge IV in the left AC, infusing normal saline at 100 mils per hour, and is on O2 via nasal cannula at 4 liters. Patient was given propofol in surgery and had no difficulties and is breathing on their own without problems. Patient has diabetes and has dentures in a blue container under the cart. Patient is allergic to penicillin. Patient had several polyps removed that will be sent to the lab. Otherwise, colon looks normal. Vital signs remain stable throughout the procedure. Other pieces of information the PACU nurse will need include anesthetic medications used, other medications received, estimated blood loss, fluid replacement, urine output, unexpected anesthetic events or reactions, unexpected surgical events, vital signs and trends, and results of intraoperative laboratory tests. On page 368, table 20.3, you will find initial postoperative assessment. First on the assessment is the ABCs, airway, breathing, and circulation. Review each system. All systems should be assessed for the patient. Pulse oximetry monitoring is a non-invasive way of measuring oxygenation. You'll want to check the patency of the airway and note if there is any artificial airway present. Breathing assessment should include respiratory rate and quality, breath sounds, if they're using supplemental oxygen, what their pulse oximetry is. It should include ECG monitoring, vital signs, peripheral pulses, capillary refill, skin color, and temperature. Neurologic assessment should include level of consciousness or Glasgow Coma Scale, orientation, sensory and motor status, pupil size and reaction, intake. And remember that intake should include intraoperative fluids as reported by the ACP, and you'll want to check the IV pump for volume infused as well. Output should also include catheters, NG, and wound drains. Also, we'll need to know the estimated blood loss from the procedure. Gastrointestinal, you'll need to note vowel sounds. Verify placement if they have an NG tube, if it should be placed to suction or clamped. Nausea. And then the surgical site needs to be assessed as well. You look at the draining. You're going to look at the dressing itself and note any drainage on the dressing. Mark that. Make sure you note the details about the drainage. So color, amount. If the patient changes positions, does they have a large amount of drainage coming out? And pain, incisional pain and other pain. Laboratory and diagnostic tests, and then review the results of the ordered exams. On page 367 in your Lewis, you'll look for figure 20.1. This figure goes over potential problems in all areas. Respiratory problems will be discussed next, and you can look at table 20.6 on page 370 for more information. Airway obstruction is commonly caused by the patient's tongue and is most pronounced when supine and extremely sleepy. Proper positioning after anesthesia is important to maintain the airway. Other causes can include laryngeal edema, laryngospasm, or retained thick secretions. Hypoxemia is a partial pressure of arterial oxygen less than 60 millimeters and is characterized by signs and symptoms including agitation, insomnolence, hypertension and hypotension, and tachycardia to bradycardia. Pulse oximetry will be less than 92%. Aspiration is gastric contents that go into the lungs, and they may be caused by laryngospasms, infection, or pulmonary edema. This is a potentially serious emergency. Atelectasis or alveolar collapse is the most common cause of hypoxemia. It is caused by retained secretions, decreased respiratory excursion, or general anesthesia, and occurs when mucus blocks bronchioles or when the amount of alveolar surfactant is reduced. Atelectasis or pulmonary edema can cause hypoxemia. Bronchospasm is caused by increased bronchial smooth muscle tone, resulting in closure of small airways. This results in wheezing, dyspnea, use of accessory muscles, hypoxemia, and tachycardia. Bronchospasms may be seen more frequently in patients with asthma and COPD. Pulmonary edema is caused by accumulation of fluid in the alveoli and may be the result of fluid overload, heart failure, prolonged airway obstruction, sepsis, or aspiration. Pulmonary embolism is a thrombus that is dislodged from the peripheral venous system and lodged into the pulmonary arterial system. Hypoventilation is a decreased respiratory rate or effort, and increased arterial carbon dioxide level. This may occur as a result of depression of the central respiratory drive secondary to anesthesia and or use of opioids. Proper patient positioning. When the patient is unconscious, they should always be placed in the lateral recovery position. This can be on the left side or the right side. Once they regain consciousness, they should be placed in a supine position with the head upright. Lateral recovery position helps keep the airway open and reduces the risk of aspiration if vomiting occurs. Supine position maximizes expansion of the thorax by decreasing the pressure of the abdominal contents on the diaphragm, so makes breathing easier for the patient. Respiratory interventions include application of oxygen, via nasal cannula or face mask to keep saturation at 92% or greater. And the nurse should encourage the patient to take deep breaths. This keeps the alveoli open, increases gas exchange, and promotes return to consciousness. Effective coughing and use of incentive spirometer prevent alveolar collapse and helps move secretions to larger airways for easier expectoration. The incentive spirometer gives visual feedback of respiratory effort. You would want to give prescribed analgesic medications before this activity. Sustained maximal inspiration requires the patient to inhale as deeply as possible, and the peak of inspiration, hold the breath for a few seconds, then exhale. This should be followed by a second deep breath and cough. Reposition the patient to promote full lung expansion and loosen, encourage phlegm to be expelled. Pain management supports the depth of breath the patient can take. Again, deeper breaths work to prevent atelectasis. Ensure that the patient is adequately hydrated, thins thick secretions, and maintains integrity of mucous membranes. Chest physiotherapy mobilizes secretions and makes them easier for the patient to expectorate. Techniques for splinting incision when coughing. You can find figure 20.7 on page 372 for this slide. The patient may need to use a pillow or a rolled blanket for support when they are doing effective coughing if they have had an abdominal incision from abdominal surgery. This helps to keep the incision from splitting open. This is called splinting. The technique, with correct positioning, provides support to the incision and aids in coughing of expectoration of secretions. Cardiovascular problems in post-op. The most common cardiovascular problem in the immediate post-anesthesia period include hypotension, hypertension, and dysrhythmias. Patients most at risk for cardiovascular complications are those with alterations of respiratory function, persons with a history of cardiovascular disease, older adults, and debilitated and critically ill individuals. Hypotension can cause hypoperfusion to vital organs, including the brain, heart, and kidneys. They will need O2 and perhaps an IV bolus, but check the surgical site to look for bleeding and make sure that is not the cause of hypotension. Clinical signs may include disorientation, loss of consciousness, chest pain, and oliguria. The most common cause of hypotension in PACU are unreplaced fluid and blood loss. Other causes of cardiac dysfunction are decreased systemic vascular resistance, dysrhythmias, drugs, and measurement errors, such as taking a blood pressure with the incorrectly sized cuff. Hypertension is most commonly the result of sympathetic nervous system stimulation caused by pain, anxiety, bladder distension, respiratory distress, hypothermia, or pre-existing hypertension. Dysrhythmias are caused by hypoxemia, hypercapnia, electrolyte and acid-base imbalances, circulatory instability, and pre-existing heart disease, as well as hypothermia, pain, surgical stress, and many anesthetics. VTE, or venous thromboembolism, may form in the leg veins as a result of inactivity, body position, and pressure, which lead to venous stasis and decreased perfusion. The nurse should suspect PE in any patient with tachypnea, chest pain, hypotension, agitation, tachycardia, and dyspnea, especially when the patient is already receiving O2 therapy. Syncope or fainting is caused by decreased cardiac output, fluid deficits, or defects in cerebral perfusion. It often occurs as a result of postural hypotension when the patient ambulates. Fluid overload can occur when IV fluids are infused too quickly, when chronic disease exists, cardiac or renal in the older adult, Patients with renal failure or heart failure will be more susceptible to volume overload. Fluid retention can result from the stress response and secretion of antidiuretic hormone and adrenocorticotropic hormone and activation of the renin-angiotensin-aldosterone system. This leads to significant sodium and fluid retention, increased water reabsorption, and decreased urine output, maintaining both blood volume and blood pressure. The stress response contributes to an increase in clotting tendencies by increasing platelet production. VTE may form in the leg veins because of venous stasis, vein injury, or a hypercoagulable state. It is common in older adults, obese persons, immobilized patients, and patients with a history of PE or predisposition to clotting. Suspect PE in any patient with tachypnea, chest pain, hypotension, agitation, tachycardia, and dyspnea, especially when the patient is already receiving OT therapy, as previously mentioned. Acid-base imbalances may be seen when the patient who has irregular breathing patterns or respiratory depression associated with anesthesia. Cardiovascular interventions include monitoring of vital signs. This is usually done every 5 to 15 minutes in phase 1. It could be different depending on the facility you work in. Compare with preoperative and intraoperative to determine if vital signs are returning to baseline. Call the surgeon if any of the following occur: a systolic blood pressure less than 90 or above 160, a pulse rate less than 60 or greater than 120, pulse pressure or the difference between the systolic and diastolic blood pressure narrows, blood pressure trends gradually decreasing or increasing over several consecutive readings, a change in heart rhythm, or a significant deviation from preoperative readings. Treat hypotension with oxygen therapy to promote oxygenation of hypoperfused organs. Give IV fluid boluses to normalize blood pressure. Inspect surgical incision for excessive bleeding and look for the cause of volume loss. Assess for hypertension centers by removing the cause of sympathetic nervous system stimulation, which may indicate pain. So we'd want to administer their pain medication as prescribed. You may need to administer blood pressure medications as well. Patients may have been NPO, so they may not have taken their daily regimen of medications. Treatment is directed toward removing the cause or a physiological alteration. Medication treatment for primary heart dysfunction and advanced cardiac life support may be initiated for life-threatening dysrhythmias such as VTAC. Early ambulation increases muscle tone, stimulates circulation, and prevents venous stasis and VTE. VTE prophylaxis is recommended for patients with multiple risk factors for VTE, non-ambulatory, or a previous history of VTE. You may use a low molecular weight heparin to treat this. The more non-invasive would be sequential compression devices. These are generally used in the OR and they are continued until the patient is mobile again. Make sure to use slow position changes to prevent syncope or postural hypotension. Just get your patient up very slowly and do position changes one at a time. Don't let your patient go from lying to standing. Make sure that you stop, put them on the bedside, let them sit at the bedside and acclimate before they stand. Once they stand, don't let them walk until they've acclimated to standing. Neurologic and physiologic problems. Patients are unconscious during surgery. Opioids are given for pain management, and neuromuscular blocking agents may be given to prevent patient movement on the operating table. These medications need to clear the patient's system for return to baseline neurologic function and mobility status. Emergence delirium is short-term neurologic change manifested by behaviors such as restlessness, agitation, disorientation, thrashing, and shouting, and may be the result of the type of anesthesia used, hypoxia, bladder distension, pain, residual neuromuscular blockade, or the presence of an ET tube. This is more commonly seen in the older adult. Delayed emergence may result from prolonged action of opioids, sedatives, residual neuromuscular blockade, and inhalation agents. Patients may also experience anxiety from waking up in an unfamiliar location or by experiencing pain. Anxiety and depression may also occur with the loss of a body part from the surgical procedure. Postoperative cognitive dysfunction, including memory loss and inability to concentrate, may continue for weeks or months after surgery and is most commonly seen in the older adult. Alcohol withdrawal delirium results from alcohol withdrawal postoperatively. Clinical signs include restlessness, insomnia, nightmares, irritability, and auditory or visual hallucinations. You'll want to monitor your oxygen levels with pulse ox. Continuous pulse ox and oxygen therapy should be applied for a patient with hypoxemia. Maintain patient safety with the use of side rails, securing equipment such as IVs and artificial airways, monitoring physiologic status, having a call bell available, and using 2 patient identifiers before giving drugs or completing treatments. Excessive pain may also contribute to confusion and disorientation. Provide pain medication as ordered. Complementary measures such as music therapy or acupuncture may support pain management. Pain may also lead to other complications, as before, can lead to shallow respirations and an increased risk for atelectasis. Pain may also delay return of gastric or bowel function. Neuromuscular blocking agents will prevent voluntary muscle movement and contribute to anxiety and stress. Reversal agents can be given to reverse these effects. These should be administered in phase 1. Anxiety and depression may occur and correlate with an increased likelihood for complications. These responses may be part of grieving for a lost body part or altered body function or the loss of independence. Alcohol protocols may need to be initiated if withdrawal is suspected. Alcohol withdrawal may present as agitation, confusion, or irritability. Electrolyte imbalances should be corrected, as this can also manifest as confusion or irritation. Bowel and bladder function should be assessed. The need to pass bowel or urinate without the ability to do so may contribute to irritation or agitation. Sleep-wake cycle may be disturbed, typically seen in phase 2 and extended observational areas. In the older adult, this may contribute to confusion. If the patient is confused, special attention must be placed on patient safety. Confusion will leave the patient at a higher fall risk or at a risk to inadvertently remove, pull invasive lines, or injure surgical site. Physiologic factors of pain include irritation of skin and underlying tissues by incision and retracting during surgery, reflex muscle spasms, positioning during surgery, and placement of various tubes may also contribute to pain and discomfort. Psychologic factors include fear and anxiety. Other sources of discomfort include nausea and vomiting, environmental noises, noxious odors, and shivering. Interventions include a plan for pain control that started at admission preoperatively. Patients are taught to report pain and how it will be managed postoperatively. Single pain control modality may be used postoperatively. This is only one type of medication and one administration type. Multimodal analgesia is the use of 2 or more analgesics given by various routes with different mechanisms of action, such as an opioid and NSAID. These are recommended when possible to achieve better pain relief with fewer or less severe side effects. IV opioids provide the most rapid relief from pain, whereas NSAIDs decrease inflammation and pain. PCAs involve self-administration of predetermined doses of analgesia via IV, epidural, oral, or transdermal route. Perineural local anesthesia is the infiltration of non-opioid medication into the surgical site, and it's another method of managing postoperative pain. A disposable or mechanical infusion pump is used to deliver the local anesthetic via a catheter directly to the surgical incision site. Alterations in temperature. Hypothermia is a core body temperature less than 96.8, and it occurs when heat loss occurs faster than heat production. See page 376. I'm sorry, page 377 for more information on temperature. Contributing factors to hypothermia are skin exposure during surgical procedure and use of cold irrigants and skin preparation, as well as unwarmed inhaled gases. The nurse should apply warm blankets as the first defense. Shivering can increase resting energy expenditures and oxygen consumption. Carbon dioxide production contribute to increased heart rate, increased blood pressure, and intracranial pressure, as well as significantly affect the patient's comfort level. Fever is often related to infection and may occur at any time during the postoperative period. Wound, respiratory, and urinary tract and IV sites are the most common areas of infection. Malignant hyperthermia, MH, is a muscle metabolism disorder. It is triggered by general anesthetic agents. Although it is often a late sign, it is characterized by a rapid rise in core body temperature to 105 or greater and severe muscle rigidity. Other signs include tachycardia, hypercarbia, metabolic and respiratory acidosis, myoglobinuria, and elevated creatinine kinase levels. It is a life-threatening complication. Most causes of MH occur during general anesthesia, but the 1 hour period right after surgery, usually in PACU, is a critical time. It is a life-threatening complication and most often occurs during general anesthesia. And as I mentioned, it may be seen in the 1 hour period immediately following surgery. Nursing interventions to prevent hypothermia and fever include taking the patient's temperature on arrival to the PACU and every hour if the patient stays normothermic. If the patient is hypothermic, you need to take the temperature every 15 minutes until normothermic is reached. Routes of measuring temperature during the patient's stay should stay the same. If you take your patient's temperature under their arm, then you should take their temperature under their arm for every time you take temperature on them. Passive warming measures include warmed cotton blankets, socks, reflective blankets, and limiting skin exposure. Active warming can be achieved with the application of external warming devices such as a bear hugger, a radiant warmer, and heated, humidified oxygen and warmed IV fluids. Oxygen therapy is used to treat the increased oxygen demands caused by shivering. Opioids can be used to treat malignant hypothermia, and Dantrium is a skeletal muscle relaxant that is used to treat malignant hypothermia. Meticulous asepsis should be used in caring for the surgical incision as well as the IV site. Coughing and deep breathing, as well as incentive spirometry, will help keep the patient's airway clear. Gastrointestinal problems. Postoperative nausea and vomiting is the most common complication. It affects as many as 80% of high-risk patients and may lead to increased hospital length of stay and patient dissatisfaction. Patients less than 50 years of age, female, history of anesthesia or opioids used during the surgery, history of motion sickness or post-op nausea and vomiting, non-smoking status, and the duration and type of surgery will all affect the GI system. Delayed gastric emptying and slow peristalsis that result from handling of the bowel during abdominal surgery contribute, as does starting oral intake too soon after surgery. Constipation may occur postoperatively due to anesthetics used during surgery that may paralyze the intestine, immobility, alterations in diet, and fluid intake pre- and postoperatively, and the use of opioids for pain relief. Risk of a postoperative ileus include the use of opioids, immobility, older adults, previous abdominal surgery, early postoperative feeding. Use of opioid analgesia may prolong the duration of a postoperative ileus. Hiccups are the intermittent spasms of the diaphragm. They're caused by irritation to the phrenic nerve, which innervates the diaphragm. This may be caused by the presence of an NG tube or drinking hot or cold fluids. Nursing interventions include assessing for the presence of nausea and vomiting. When ordered NPO, the patient may be kept hydrated with IV fluids. Begin oral intake when gag reflex returns and patient can tolerate. Position the patient in the lateral recovery position if they are experiencing post-op nausea and vomiting and have suction equipment available. Antiemetics will work to decrease feelings of nausea, whereas prokinetics will increase GI motility. Verify hydration status and blood pressure of the patient. An NG tube may need to be placed specifically with GI surgeries until the return of bowel function. Complementary measures such as guided imagery may support the nauseated patient. Assess for adequate hydration, specifically if the patient is vomiting. Assess for electrolyte loss with use of NG tube and suctioning of GI contents or vomiting of GI contents. Be alert for risk of aspiration while patient is still sleepy from anesthesia. Assess for return of bowel function. Increased mobility, although there is limited evidence regarding early ambulation and decreased abdominal distension, it is still a standard postoperative intervention. Urinary interventions. Need to monitor urine output, have a working knowledge of the type of procedure, and if renal ischemia or cardiovascular compromise could have occurred. Make sure patient is given IV fluids as ordered. They may need them as a result of fluid loss in OR or GI losses. If the patient remains NPO, they will require hydration support. Monitor output with a Foley if clinically indicated. If not, remove the Foley as soon as possible to prevent a catheter infection and patient's ability to initiate voiding. If able, place the patient in a normal position for voiding if they are having difficulties. For males, this may mean standing and or sitting on commode versus bedpan to pass urine. Providing privacy, running water, offering water for the patient to drink, or pouring warm water over the perineum. Walking and the use of bedside commode or other measures to help with voiding. If urine output is absent or low, a non-invasive measure would be to perform a bladder scan to determine if the patient had urine retention. If indicated, the patient may require being straight cathed until return of the ability to initiate voiding. Surgical site infections. They continue to represent the most common healthcare-acquired infection and account for 14 to 16% of hospital-acquired infections. Surgical site infections are associated with prolonged hospitalizations, increased cost of care, and poor patient outcomes. The majority of surgical site infections are preventable with evidence-based strategies such as hand hygiene, selection, timing, and duration of prophylactic antibiotics, and surgical site skin preparation, maintaining preoperative normothermia. Evidence of surgical site infections usually does not become clear before the 3rd to 5th postoperative day. Local manifestations include redness, swelling, and increasing pain and tenderness at the site. Systemic manifestations are fever and leukocytosis. Wound infection may result from contamination of the wound from 3 major sources: exogenous flora from the environment, oral flora, intestinal flora. Pressure may develop if drainage under the incision accumulates. The surgeon may place a drain in the incision or make a stab wound adjacent to the incision to allow for drainage. Dehiscence or separation of previously approximated wound edges may occur with wound infection. Brown, pink, or clear drainage may precede wound dehiscence. Infection should be suspected and wound cultures should be obtained. Immediately after surgery, check the wound every 15 to 30 minutes or as ordered. When drainage appears on the dressing, record the type, amount, color, and odor of the drainage. Assess the effect of position change on drainage. The incision may be covered with a dressing right after surgery. Many healthcare providers prefer to change to the first postoperative dressing. If the initial operative dressing is saturated, follow your agency's protocol as to whether you should change or simply reinforce the dressing. Assess the wound for signs and symptoms of infection. Wound should go from sanguinous to serosanguinous to serous. So from red to pink to clear yellow. Type, color, amount, and odor of drainage, if present, should be noted. Also note if there is an increase in drainage when moving the patient. Note signs and symptoms of infection. These should be monitored for fever or warm red skin surrounding the incision. Administer antibiotics as ordered. There are protocols for type of antibiotics and duration of antibiotic use as prophylaxis depending on the type of surgery. And always maintain glycemic control. Hyperglycemia can contribute to risk for wound infection. The modified Aldrich scoring system or other forms of post-anesthesia scoring systems may be used to determine the patient's readiness to transition from phase 1 to phase 2. It is a modification of the APGAR scoring system used with newborns. It has since been modified to more critically evaluate the patient's oxygenation status, hence the word modified. The modified Aldrich scoring system takes into consideration the patient's consciousness, activity level, respirations, oxygenation, circulation status. And a score of 9 to 10 indicates readiness for transfer. Upon meeting specific criteria, patients are transferred from phase 1 to phase 2 care. Phase 2 is an inpatient unit. The inpatient unit chosen should be appropriate for the patient's surgical procedure or condition to better meet postoperative needs. Before sending the patient to phase 2 care area, the patient should have a return of neurologic baseline, aware of situation, oriented, able to follow commands, be hemodynamically stable, blood pressure and heart rate are baseline or close to baseline without anticipated changes. Surgical site should have minimal drainage. Pain should be managed with a continued plan for further management. SBAR is a standardized communication tool that is used to provide a complete report. SBAR, situation, background, assessment, recommendation provides a complete report and enhances a safe transfer of the patient from PACU to the clinical unit. Nurse-to-nurse communication is essential when the patient is moving from phase 1 to phase 2 care. Phase 2 care is inpatient setting. Nursing care focuses on preparing the patient for managing care at home or in an extended care environment such as rehab. Consider nursing care required during this time frame and equipment required for care for this patient. Equipment would include the equipment required to care for the surgical procedure condition of the patient and may include surgical incision assessment, dressing change material. It may include braces or splints or ambulatory assist devices if a joint was replaced. This is the equipment typically required for a post-surgical patient in the clinical setting. Some equipment, such as means to measure vitals, are the same. However, equipment required for intense monitoring is not included. Added to the list is equipment such as bladder scanners, required to measure urine output and perform urinary straight catheterization if required. Lists of equipment required for specific surgery should be verbalized during report from the PACU to the clinical unit, so the receiving unit is prepared to meet the patient's needs. The last thing the PACU nurse should do before transferring the patient is to always check a set of vital signs to ensure the patient is still stable. Extended observations. The patient may need to be transferred to an extended observation area such as a rehab facility or remain on an inpatient unit for rehabilitation. An example of this would be a hip surgery. Nursing care continues to focus on preparing the patient for discharge home and self-care. Equipment required depends on the type of surgery, the patient population, and the facility guidelines. Discharge criteria from the ambulatory surgery center. All PACU discharge criteria phase 1 must be met. No IV opioids can be given in the last 30 minutes. Patient must have voided if appropriate for surgical procedure. They must be able to ambulate if not contraindicated. However, they will leave the facility in a wheelchair. They cannot drive home, so they must have someone with them who will drive. They must have written discharge instructions, and the nurse must go over them with the patient and whoever brought them or will be caring for the patient at home. And the patient must understand the instructions. Discharge from ambulatory. The patient leaving the ambulatory surgical setting must be near preoperative level of functioning. A responsible adult must be present to transport the patient from the PACU. Postoperative teaching is provided to the patient and caregiver and reinforced with written instructions. A post-anesthesia scoring system similar to the modified Aldrich scoring system may be used to determine discharge readiness. Discharge teaching from ambulatory surgery should prepare the patient's discharge is an ongoing process that begins before surgery. Needs to be provided to the patient and caregiver. It's specific to the surgery and anesthesia used. Incision care and dressings must be reviewed with the patient and caregiver. Medication education, especially pain medication, must also be reviewed with the patient and caregiver. Activities allowed and prohibited should also be reviewed, and dietary restrictions and what is allowed. Discharge education is of the utmost importance. Patients and their caregivers are expected to continue self-care of incisions, tubes, drainage systems at home. In collaboration with the case manager, patient care navigator, discharge planner, the nurse helps to facilitate a safe transfer home. Consideration for access to pharmacy, a phone in case of emergency, and access to follow-up care must occur. Discharge teaching. From the ambulatory setting. Common reasons to seek help after discharge include unrelieved pain, questions about medications, wound drainage and or bleeding, increased drainage from the drainage device, or a fever greater than 100.5. You have to consider hemodynamic stability, so a return from baseline BP to heart rate or near baseline baseline mentation or neurologic status, and adequate urine output. Pain must be managed and patient reports pain is tolerable. Surgical site dressing is without excessive drainage. Tubes, drains are draining expected color and consistency of drainage and expected amounts. Fluid and hydration, the patient must be taking PO, or if they're in PO, they must be receiving fluids via an IV. A Foley may be in place or the patient may be voiding. No symptoms of dehydration, such as increased heart rate or hypotension, are noted, or fluid overload, which would be rales or generalized edema. The patient's mobility status is assessed and monitored dependent on the type of surgery. Early mobilization can prevent numerous complications and is an early goal. The patient may be receiving narcotics that may affect mobility status, so patient safety is a priority during this time to prevent falls and other injuries. Patient safety needs to be maintained by positioning in bed, fall precautions, and use of assistive devices. Interactions are important with significant others as they may be the caregivers upon discharge. Discharge teaching should include education for the patient and their caregiver. Discharge criteria may vary based on the types of surgery performed. Care during phase 2 focuses on educating the patient to assess and potentially manage tubes, drains, and other care associated with the surgical incision procedure. The gerontological considerations include decreased respiratory function, including decreased ability to cough and decreased thoracic compliance. These can lead to an increase in the work of breathing and decreased ability to eliminate drugs. Altered vascular function as a result of atherosclerosis and decreased elasticity of blood vessels, along with the possibility of decreased circulating volume and hypertension, may lead to cardiovascular problems. Renal function in the older adult normally decreases, causing a reduced ability to remove drugs and increasing the risk of drug toxicity. Decreased liver function also leads to reduced drug metabolism and increased drug activity. Age, history of alcohol abuse, and poor baseline cognition, hypoxia, severe metabolic imbalances, and hypotension may contribute to postoperative delirium in older adults. Older adults may hesitate to ask for pain medications. They may have impaired communication, or they may have physiologic changes that affect how drugs are metabolized.